I noticed that we've got quite a long chunk coming from Emma. Did you want to ask?
Some of that's been removed though, so she's taken out this whole much less commonly psoriasis part. Yeah, we just don't have it on our copy.
We're not including release psoriasis; it doesn't come in.
Yeah. Emma, you're actually very good with the monologues.
With the monologues.
Yeah, which is interesting. Usually people are horrible at monologues. You're quite you've got a nice variation in the way you...
Okay.
Monologue aficionado.
Don't jinx it. Okay.
Yeah, you're good.
Back to the other causes of vulval itch. How do we exclude other causes?
I think we have the
Sorry.
cup come down.
Back to the other causes of vulval itch. How do we exclude these causes in our LS patients? And what tests should we perform to diagnose and exclude these causes?
It's important always to remember other conditions that can coexist with LS, in particular eczema or dermatitis and thrush. Thickened eczema or lichen simplex chronicus may arise from chronic scratching of the underlying LS. Otherwise, irritant contact or, less commonly, allergic contact dermatitis can arise in the setting of LS. Clues in the history for a coexistent irritant dermatitis are their washing practices. Are they washing with imperial leather soap or Dettol, which is common? Do they have some level of urinary incontinence? Are they using wipes to clean, and how often are they washing? Just water alone will trigger irritant contact dermatitis. Dermatitis will present with more widespread erythema, particularly over the labia majora, extending into the inguinal creases and perianal area, often with areas of lichenification. Thrush may also coexist with LS and present with a flare and itch. Clues in the history for thrush include a premenstrual flare and itch, associated discharge, soreness, burning, recent antibiotic use, the use of a local estrogen, a history of poorly controlled diabetes, and diabetic medication that increases urinary glucose, such as empagliflozin. I meant to practice this. Such as empagliflozin.
Gliflozin, I think you have to say. Empagliflozin.
You want to just say the drug class instead?
No. Oh, yeah, the drug class. Yeah.
Yeah, that's a good idea.
Is it the SLG?
SLG2? I think
SLG2.
SLGT2, I think.
I was just thinking about how to Google it properly. Yeah.
SGLT2. SGLT2. The SGLT2 inhibitors. And diabetic medication that increases urinary glucose, such as the SGLT.
It's easier to say it.
and diabetic medication that increases their urinary glucose. I might just leave it at that. And, okay.
I think it's useful to say, though, because I feel like...
Yeah, it is.
We've had a couple recently.
It's common. And diabetic medication that increases the urinary glucose, such as the SGLT2 inhibitors. And also, it'll get worse with the topical steroids.
Apart from itch, what symptoms might patients with thrush experience?
Women will commonly experience soreness, burning and stinging with urination, along with vaginal discharge and pain with intercourse, and a postcoital flare in the itch.
What are the different causative organisms for thrush?
Most commonly, it's Candida albicans, but around 10 to 20% of recurrent thrush will be the non-albicans Around 10 to 20% of chronic recurrent thrush will be non-albicans, namely Candida glabrata, and it's important to do a swab, particularly if they haven't responded to the initial treatment.
And what examination findings would you expect?
Often in these cases, the vulva is quite red and swollen. There'll be fissures in the intersulci area as well as the perineum, and they can also have white discharge on the coating the vulval area. If you look closely, they'll also have these satellite red lesions that can spread from the labia majora going out to the perianal area. Be mindful to monitor and look in the other areas of the body, in the groins, under the breast, and on the perineum as well. If the patients are Sometimes if you do the examination during their cycle when they're menstruating, the findings can look completely normal as well.
Should we routinely perform a swab to confirm thrush?
Ideally, yes. However, this is often not practical, and many women will report that they know exactly what their thrush feels like and they can self-manage this. However, particularly in recurrent thrush or itch not responding to treatment, then a swab is important.
How do you treat simple thrush?
Usually this can be self-managed with over-the-counter treatments such as a single dose of fluconazole, 150 milligrams, or a vaginal azole cream such as clotrimazole inserted at night as a single dose, or nightly for 3 to 7 days, or clotrimazole pessary as a stat dose.
Recurrent vulvovaginal candidiasis is a particularly common issue that I see in GP. How do you approach managing this?
There are many different approaches, depending on which country you're practicing in. My regime, which is based on several different guidelines, is to use fluconazole 150 milligrams every third day for 3 doses, then 150 milligrams once a week for 6 months. This generally works very well in suppressing recurrence while on treatment, but unfortunately relapse is high on stopping. If they're unable to take the fluconazole, then I would use nystatin cream nightly for 2 weeks, then once a week also for 6 months, or an azole cream or pessary. And new therapies are available in the US, but unfortunately not yet in Australia.
What about thrush in pregnancy?
Sorry, let's get that one more time, please.
Oh. What about thrush in pregnancy?
This is actually very common. The increase in hormones in pregnancy puts patients prone to getting thrush. A lot of patients, though, are not symptomatic from their thrush in pregnancy, so only treat if they are symptomatic, if they're having issues with itch or irritation. The preferred management would be a 6-day course of clotrimazole, and often they need to repeat this a few times as well. Alternatively, they can safely use nystatin cream or pessaries as well. Unfortunately, in pregnancies, we would not be using fluconazole, boric acid or itraconazole. These are all contraindicated during pregnancy, but safe to use whilst breastfeeding.
Are there any risk factors for developing recurrent candidiasis? And is there anything patients can do to modify their lifestyle to prevent future recurrence?
All patients will ask you this and want to know what they can do differently, in particular what dietary factors might be playing a role. Most have tried a low yeast or low sugar diet, for example. I reassure them that thrush and chronic thrush generally affects healthy women, that there is nothing wrong with their immune system, and that unless they have poorly controlled diabetes, then diet won't be playing a role. The only proven risk factors, as I mentioned earlier, are poorly controlled diabetes, topical estrogen, broad-spectrum antibiotics, and certain diabetic medications, namely the SGLT2 inhibitors, which increase glucose in the urine, and it is not related to dietary sugar or yeast. Importantly, reassure them that treating their sexual partner does not make any difference, and neither do probiotics.
Now moving on to a neighbouring genital dermatosis.
Actually, can I make a comment? So when I started this podcast, I was talking to Karen Freelich, and she does a podcast for medical students. Yeah. And she's a sexual health physician or has interest in it. And she said, if you're going to do a podcast, I want you to make one with thrush specifically. Because that's very, very difficult to manage.
Very.
So there you go. I'll tell
Excellent.
her.
We're doing it. We're doing it.
This is before anything started. She says, we need one in thrush.
Yeah.
Okay.
It's a really hard topic, though.
Sorry?
That's why I gave it to Emma.
It's tough.
I'll take the fire.
It's a really hard one.
We see it so much in general practice. I'd love to see what the numbers are at the moment because I just see so much.
Yeah, it's a tough topic.
I'm
We
going
can
to
change the wording.
Yeah, I'm just looking.
That's fine.
Now moving on to a different genital dermatosis, lichen